Good afternoon, everyone. Welcome to today's webinar, and thank you for joining us. My name is Deanna Hoelscher, and I am Director of the Michael and Susan Dell Center for Healthy Living and the Campus Dean at the UTHealth Houston School of Public Health in Austin. Today's webinar is co-hosted by the Texas Pediatric Society and the Michael and Susan Dell Center for Healthy Living. The goal of the Texas Pediatric Society is that all children in the state attain their full potential for physical, emotional, and social health. And our center's vision is healthy children in a healthy world. So those really are very consistent with a lot of what we're going to talk about today. This webinar is the final installment in our three-part series on food insecurity in Texas. We first introduced this topic from a public health and pediatrician perspectives. Then next, we discussed clinic and community-based approaches to combat food insecurity. And finally, our third webinar today will focus on policy approaches to food insecurity. So altogether, these make a nice package and kind of overview of this issue in Texas. If you're interested too, we have the previous two webinars archived on our website, and this one will be archived as well. So before we get started, I wanted to make a few housekeeping announcements. One is this webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. And we'll have that again in the chat later on. If you have any questions during the presentation, please enter them into the questions chat box. We will have time for a Q&A at the end of the presentation. And so with that, I'm very excited to introduce our speakers for this afternoon, Dr. Valerie Smith and Jaimie Olson. So Dr. Smith is an assistant professor of pediatrics and pediatric clerkship director at the University of Texas Tyler School of Medicine. She is a graduate of the University of Texas Southwestern Medical School, completed her residency at Arkansas Children's Hospital, and received her MPH from the University of Texas at Tyler. She was recently appointed the Smith County Local Health Authority. Dr. Smith is on the board of directors of the East Texas Food Bank and Texans Care for Children. She is currently TPS Secretary Treasurer and co-chair of the TPS Executive Legislative Committee. She also serves on the American Academy of Pediatrics Committee on Federal Government Affairs and as the AAP District Catch Facilitator. In addition, she serves as a consultant for Superior Healthcare on their Foster Care Centers of Excellence program and served as the inaugural Child Welfare and Health Policy Fellow at the American Academy of Pediatrics. She is active in pediatric health advocacy and regularly testifies for the Texas legislature and authors editorials for the Dallas Morning News. Jaimie Olson is the Director of Policy and Advocacy for Feeding Texas. In this role, Jaimie focuses on federal and state policies around food, nutrition, and economic development. Previously, Jaimie worked as the policy analyst and as supply chain manager for Feeding Texas and as senior program associate at the Cynthia and George Mitchell Foundation. Along with a diverse background in both the nonprofit and public sectors, Jaimie holds a Master's of Global Policy Studies with a specialization in energy and environmental policy from the University of Texas at Austin and a Bachelor of Arts in Political Science from Temple University. I can't think of two better people to really present this afternoon. So I'll now hand it over to them to start their presentation and policy, state level policies to make an impact.
Thanks so much, Deanna. Next slide. All right, so as Deanna said, my name is Jaimie Olson, and I'm the Director of Policy and Advocacy at Feeding Texas. I briefly wanted to touch on Feeding Texas. So we are a network of 21 food banks across the state of Texas, You see their service territories colored there on the map on your screen. So our food banks collectively serve all 254 counties in the state, and they provide a variety of services in those communities. Of course, we do the traditional emergency food assistance for anyone that needs our services or is in need of food. They can come to one of our distributions with over 4,000 local food pantries in our network across the state. But we also provide nutrition education classes, workforce development, training. We also have a contract to do SNAP outreach and application assistance. So all of our 21 food banks have trained staff available to help folks apply for SNAP and many other community programs as well. So next slide. So why are we here today talking about hunger? Texas is a great state, and Texans are usually very proud. But unfortunately, one of the things that we are ranked highest at in the nation is having the highest rate of hunger. So we were roughly in the top 5 states with 13.7% of all Texans, or roughly 1 in 9 Texans, all being food insecure. And that just means that they don't know, where their next meal is coming from, or they're worried about not having enough money to make it to the end of the month. Folks are, cutting back on meals in order for their children to be able to eat. All of those things manifest as food insecurity. And a lot of what I'm going to talk about today in the policy realm focuses on SNAP, or the Supplemental Nutrition Assistance Program. And the reason for that is that SNAP is the nation's #1 tool for fighting hunger. It is our largest anti-hunger program and the most efficient. We have a saying in food banking that we can't food bank our way out of hunger. We need public-private partnerships to address this issue. And for every 1 meal that Feeding America Food Bank provides, SNAP provides 9. So it's a very critical program, and our food banks could not make up for SNAP. If there's any cuts to the program, it would be impossible for our food banks to fill in the gap. That said, SNAP is not enough for most families. As you can see, the average SNAP benefit per meal in Texas is only $1.97. So it's very low. You can't eat at McDonald's for $2 these days. And so we know that SNAP does not make up 100% of a family's food budget. And so we need to keep working to make the program more adequate to meet families' needs. Next slide. I do want to highlight one of the current issues affecting Texans today at the state level, and that's with the Texas Health and Human Services Commission, the state agency that administers SNAP. So at the root of this, it's a staffing issue. HHSC is currently understaffed, which is creating a timeliness challenge, and I'll talk for a second in a minute about it and what timeliness is and why it matters. And that causes delays in people receiving their benefits. Next slide. So what you see here is sort of the current problems. We noticed in 2022 that HHSC had a major backlog in both Medicaid and SNAP applications. They're both handled by the same eligibility workers at HHSC, and renewals in 2022. In early 2022, we were notified that HHSC was facing about a staffing shortage of 1,000 eligibility workers. And they had about I think a 300,000 case backlog, which is quite extraordinary. In August of 2022, HHSC underwent several efforts to hire more staff, and the most critical thing that they did was increase the base salary for eligibility workers. This 25% salary increase enabled them to fill some of those vacancies, and we were notified in December that they had a shortage of only about 300 workers, down from that $1,000 or 1,000 position vacancy earlier in the year. So they still do have about a 6% vacancy rate, but it's much better than the 21% vacancy rate we previously saw. It's critical to understand this because funding HHSC's budget request, their LAR or legislative appropriations request, for both the supplemental bill, which looks back at 2023 and covers that increase that they did make, as well as the budget looking forward for the 24 and 25 fiscal years, is critically important, and that's something that we're advocating for. Next slide. Here you can see why the staffing shortage is so impactful for families. It's kind of a busy slide to look at, but essentially for SNAP, the federal government says that states are required to process SNAP applications timely, which means within 30 days of receiving the application, there needs to be a benefit determination. And they're required to be 90% timely. That's that blue band that you see running across the top. And here we've tracked in green the number of new applications, and in brown the number of redeterminations when someone's reapplying for the benefit. And you can see that we have not been meeting that timeliness threshold for the majority of 2021 and 2022 into 2023. And timeliness is, a sort of, you think about it as an abstract thing, but this really impacts families. Imagine you are a family on SNAP and you've been receiving your benefits month to month, and then it's time to reapply, and you turn in your paperwork on time as you're supposed to. If it takes the agency upwards of 60 days to make a determination about your case, you are experiencing a gap in benefits. Now, when that determination is made, they provide the benefits retroactively back to your previous, last month. So you do receive the funds, but while you are waiting, those 60 days while you're just waiting for them to make a determination, you're going without benefits. And it's critical for you to feed your family. So this manifests in a very real problem for a lot of families, and honestly, shouldn't be an issue if the agency were fully staffed and were able to be timely in those redeterminations. You see those gray bars going up and down, and those indicates periods in which FNS has been using federal COVID-related waivers to extend SNAP recertifications. So instead of having families do their redetermination every 6 months, they've been pushing folks out to every 12 months. And this is a policy that we're advocating for at the state level as well, which I'll talk about in a little bit. Next slide. So here's some legislation that is currently pending in the 88th Texas legislature. Next slide. I put this slide first because it is our #1 priority this session is modernizing the SNAP vehicle asset limit. And I should have said, you know, I'm here today representing Feeding Texas, of course, but I also co-chair something called the Texas Food Policy Roundtable, which is a coalition of over 60 organizations in the state dedicated to ending hunger in Texas. And so this is also the Texas Food Policy Roundtable's #1 priority this session. The SNAP vehicle asset test is simply a limit that is placed on the value of a family's vehicles that they can own and still qualify for the program. And you see them listed on the right. The value for the first car is $15,000. That has not been updated since 2001. The value for any subsequent vehicles, so if you have a 2-parent household or a multi-generational household and you own more than one vehicle, the limit for that is $4,650, and that hasn't been updated since 1974. And so as you can imagine, these limits keep thousands of Texas families from accessing the benefits for which otherwise they would be income eligible. And we are advocating for a set of bills, HB 1287 by Representative Guillen and SB 273 by Senator Blanco, that would modernize this policy by implying an inflationary adjustment, which is, you know, just super critical considering how outdated the limits are. But also we've seen a phenomenon happening over the last year or so due to really high inflation in the used car market. Families that previously qualified for SNAP under these current limits, when they go to recertify, they're actually having their SNAP benefits taken away from them because the value of their vehicle increased rather than decreasing just due to inflation in the used car market. And it's tragic because I hear families, they call me and they say, you know, Jaimie, we just don't understand. We haven't bought a new car. Our situation hasn't changed. We still need the food assistance. And yet, you know, they are having their assistance taken away due to no fault of their own. And so we critically need an update to this policy. And if you can go to the next slide. The next slide is a bar chart that shows the number of denials due to the vehicle asset test over the past several years. And when the slide comes up, hopefully we'll be able to see that in 2017, 18, and 19, you can see a relatively stable number of denials due to the vehicle asset limit. It was hovering around 13,000 denials per year. There we go, slide 9. 13,000 denials per year. In 2020, you see it jump up more than double, and that's due to the COVID-19 pandemic and more families applying for SNAP. Since there's more folks applying, you can, you know, assume there's going to be more denials due to the vehicle asset limit. But what we see in 2021 and 2022 is it still is climbing. We're up to over 64,000 denials due to the vehicle asset limit in fiscal year 22. And if you look at the number of total applications, which I don't have on this slide, I should add a line, but the number of total applications from 2020 to 2021, 22 is actually staying relatively level and then falling in 2022, whereas the denials due to the vehicle asset limit is still sharply rising. And that's because of car inflation in the used car market. So that's what's going on there. And as I said before, we just critically need an update to this policy. Next slide. So this bill, HB 2836, by Representative Wally, addresses the certification and recertification issues. As I mentioned before, families with children on SNAP are currently required to recertify every 6 months. And we know that circumstances for low-income families do not drastically change during 6 month period. They stay eligible for the most part. But what happens is with these frequent recertifications, families have a 10-day window in which to complete the recertification process, which includes an interview that they have to complete. And that is a very short window for most families, and that is the cause of most of them failing to recertify in a timely manner. And so what happens there is they drop off the program and then have to reapply as if they were a brand new applicant, which also creates a gap in benefits for the family while they're waiting for their new application to be processed. And it also creates more burden for the state agency. So when I talked earlier about the state agency sort of struggling to keep up with applications, this is adding to that problem. And so the federal government allows states to move to 12-month continuous eligibility for SNAP, as we have recently done for Medicaid with families with children. And that's what we're hoping to do in Texas. Most states already do this, so that's a best practice. And as I mentioned before, we've been doing this as sort of a stopgap measure to try to allow the agency to catch up. But those waivers that they're currently taking advantage of due to COVID will end with the end of the public health emergency in May. So we need to make this a permanent policy change. And that's what HB 2836 would do. Next slide. I'll briefly mention hunger at community colleges. So SNAP access for college students is actually very restricted at the federal level. So that is something we are advocating to change at the federal level in the Farm Bill, which Dr. Smith will talk about a little later. But there is a little bit of wiggle room that states have and can take advantage of. Specifically for students who are enrolled in vocational or technical degree programs. Those degrees can be deemed equivalent to SNAP ENT, that's the SNAP Employment and Training Program. And if we designate vocational and technical degree programs as being equivalent to SNAP ENT, then those students can not only access the program, but then they will also be meeting SNAP's work requirements, since SNAP includes work requirements for all able-bodied adults without dependents. So this bill, HB 1501 by Representative Wally and SB 557 by Senator West, instructs HHSC to extend SNAP eligibility to college students in vocational and technical degree programs. Next slide. This one is a budget request. So the Surplus Agricultural Products Grant is a grant that's been around since 2001. And it supports Texas food banks in procuring healthy, fresh fruits and vegetables from Texas farmers. So it's really a win-win-win. It supports Texas agriculture, it feeds hungry people, and it reduces healthcare costs because it improves the diets of low-income families. But healthcare costs both for individuals and for the state of Texas, since most of those families qualify for Medicaid. And so we are asking the legislature to double the grant from 10 million to 20 million for the biennium, primarily because of inflation and the demand that we're currently seeing at our food banks due to the end of some COVID era benefits. So as you may have heard, SNAP emergency allotments ended last month in February. This was an extra benefit that all SNAP families were receiving due to the COVID-19 pandemic. It totaled $346 million per month for families in the state of Texas, and that ended in February. So all of our food banks this month are bracing for an increase in demand for people seeking food assistance. And inflation is high, which not only hurts families when they're at the supermarket, but also hurts our food banks when we're trying to, purchase food and fuel. And so, as I mentioned, we are asking the legislature to double this grant in this legislative session. Next slide. And I believe this is my final slide. We have another bill, HB 2983 by Representative Olson, called the Healthy Food is Good Medicine Act. And this bill would institute a pilot program that would provide Medicaid reimbursement for healthcare physicians and community partners that prescribe medically tailored meals. So medically tailored meals is a nutrition intervention for people with chronic illnesses and other conditions that make it hard for them to prepare their own meals. And so it's a very specific diet that is prescribed by a physician and then prepared for the patient by a community-based organization, and it would provide Medicaid reimbursement to both the physician and that community-based organization for providing the meals. And at this point, I will turn the presentation over to Dr. Smith.
Thanks so much, Jaimie. Really appreciate all of those pieces of what's happening in this legislative session that really can help move forward work that's happening in the state to improve food insecurity and reduce food insecurity for the children and families that we serve. I wanted to start just by tagging on to that piece that Jaimie was just talking about related to food as medicine and why as healthcare providers this really makes sense, and that I'm really excited about the prospect of Medicaid being able to utilize funding for programs like this. There's the bottom of the slide has a link so that when you all get the slides, if you want to look, the Harvard School for Public Policy has done a really lovely job of compiling the evidence base for food as medicine programs, and just wanted to hit the highlights of those in that food as medicine programs kind of across the board consistently show improvement in food insecurity for patients who participate in them, improvement in dietary quality, decreased inpatient admissions and emergency room admissions, and so thus the decreased medical spending and healthcare costs make a lot of sense. And then for some of those pieces, such as medically tailored meals that Jaimie mentioned, some specific target populations. So many medically tailored meal programs have been focused on people with diabetes, and they have seen significant decreases in hemoglobin A1Cs. And then there have also been some targeted towards pregnant women on Medicaid in other states that showed decreased rates of preterm births, all of which are really important to pediatricians and healthcare providers who are working with families. And so it's our hope that this bill is able to go forward so that we are able to implement some of these programs here in Texas and build that evidence base here in Texas so that they can be accessible for more of our communities and patients and families who are on Medicaid. Next slide. And I did want to highlight one other bill, and then we're going to talk about some more administrative things that are happening at the state level around food insecurity. But that bill is House Bill 1599 by Busey, and it is what's known as express lane eligibility. So express lane eligibility allows families to utilize information that has already been collected for one state program, such as SNAP, to facilitate the enrollment of their children in Medicaid or CHIP. It is really important because we know that families who have a need in one area typically have a need in another area, right? Food insecurity doesn't exist in isolation to healthcare access, to transportation challenges, to other financial strain, that these families are often dealing with multiple pieces. And if we can improve the bandwidth for a family to be able to address one problem, so for example, if a family has an uninsured child, and they are able to obtain Medicaid or CHIP coverage for them and reduce their healthcare costs, then they have the ability to utilize those funds they were spending on healthcare costs previously for other necessities for the family. So to improve their dietary quality, for example, if they're food insecure, or to find reliable transportation, or childcare is another huge one. There are almost 1 million children, uninsured children in the state of Texas, but 400,000 of those uninsured children are actually eligible for Medicaid or CHIP. So over 40% of our uninsured children are eligible. If we can take advantage of the fact that many of these families are already participating in programs like SNAP and help use that information to enroll them in Medicaid or CHIP, we can make some great strides in reducing that number of uninsured children in the state of Texas. And improving the financial situation for those families. Next slide. So the next piece I want to talk about is really not legislative, but so many things happen at the state level from a policy standpoint that aren't in front of the legislature. And I'm really excited to share this next piece with you. The Texas Health and Human Services Commission has released recently a non-medical drivers of health action plan. It's really the first time that HHS has looked at kind of collectively and comprehensively what non-medical drivers of health are impacting the health of the patients that they're serving in the Medicaid and CHIP populations, and how HHS can help support the Medicaid managed care organizations that provide the insurance for those children and families to be able to help address these non-medical drivers of health. And you'll note that they picked 3 priority areas, food insecurity being one of them, housing and transportation. And there are a variety of reasons that these were chosen, one of which is that there are strong evidence bases for each of these 3 non-medical drivers of health impacting both health outcomes and healthcare costs for patients who are affected. And as we kind of work through the plan here in a minute, you'll notice that a lot of the early action focuses around food insecurity. Part of that is that evidence base. Part of that is also a testament to Jaimie's team at Feeding Texas and the Food Bank Network, as well as other organizations in our state, such as WIC, that have really laid the groundwork for having food access programs available for families and to be able to serve families and connect to those families. And so I'm fully aware that food insecurity would not necessarily be at the top of that list if we didn't have so many community-based organizations doing that work. I want to share, because non-medical drivers of health may be a new term for some of you. Many of you may use the term or have read the term social determinants of health. So one of the things that HHS did was spend some time really thinking about definitions. And so 2 kind of key definitions that exist throughout this action plan are that term non-medical drivers of health, which is defined as the conditions in the place where people live, learn, work, and play that affect a wide range of health risks and outcomes. And then they also are utilizing the term health-related social needs. These are the individual level social conditions that can negatively impact a person's health or healthcare. So you may hear those terms more and more in coming days, and wanted to make sure everybody was familiar with them. So let's move to the next slide, where we can kind of take a look at what this plan entails. So this plan really includes 4 goals. The first one is to build the data infrastructure for statewide quality measurements and evaluation. The next one is to coordinate services and existing pathways throughout the delivery system. The third one is to develop policies and programs that incentivize managed care organizations and healthcare providers to identify and address health-related social needs while containing costs. And the last one is to foster opportunities for collaboration with key partners. So let's talk a little bit about each of these and specifically where the plan and the goals around food insecurity fall within these goals. So that first goal, goal A, underneath that, there's a real recognition that we need to have kind of a universal language around food insecurity measures and clinical quality measures that we have, so that these can be used both for quality improvement and for evaluation as we implement new programs. So this would include the state developing that infrastructure for what are the evidence-based screening tools available, which we've talked about in some of the previous webinars for this program. What are the target populations that should be focused as we look at screening and interventions? And what is the demographic information available about those target populations as well? And then this really challenges Medicaid, our state Medicaid system, to develop a strategy to collect data about food insecurity among Medicaid recipients, so that then we can know and understand better the relationship between food insecurity and health for those patients, and then to look at statewide trends around food insecurity and kind of combine those together so that we can develop the infrastructure to really evaluate any interventions that are done in this space. The next piece, which is looking at coordinating services and existing pathways, includes identifying strategic partnerships, many of which have been mentioned already in this webinar series, between community-based organizations, state agencies, stakeholders, and then looking at enhancing a couple of state systems that already exist, right? So the first one we talked a lot about today, and that's SNAP. How can we enhance the impact of SNAP for Medicaid and CHIP recipients in the state? And then also WIC as well. So we haven't talked a lot about WIC today, but it's a really valuable and important tool, especially for families with young children, to be able to improve their food security and their dietary quality. And then the third part of this particular piece is really looking at our state 211 resource system and figuring out, are there ways that we can improve how it serves patients? I will tell you, I have a lot of families who have gotten really frustrated with 211, just in that they will call and they'll either get really long wait times, or they'll get directed to services that are no longer available or they weren't eligible for. And so really looking at how can we optimize the 211 system so that we provide more timely information to people and information that is more accurate, so that we can connect them to those resources. This is something our state is already investing in. We want it to work even better. The third goal around developing these policies and programs that incentivize MCOs and providers to help identify really are those policies that are around how do we reimburse providers for screening and referrals? How do we integrate addressing health-related social needs into value-based payment plans, pay for quality plans, and quality initiatives that exist within the Medicaid system? So my clinic that I was previously at before I recently joined the UT Tyler School of Medicine participated in a value-based payment contract with multiple Medicaid managed care organizations, which was really a lovely thing because we were able to have one set of metrics that covered 3 MCOs. But one of the criteria for reaching the highest tier of reimbursement from that value-based payment contract was that we had programs in place to help address health-related social needs. And I think we are hoping to see more and more of those things take place. And maybe most importantly, part of the goal of this plan is to look at what's happening across the state and what those potentials are, and to try to standardize them across MCOs and plans so that providers we can navigate those systems a little bit better, and we're not trying to chase one metric for one plan and one metric for another plan and getting frustrated, so that our documentation, our coding, and how we are caring for kids can be consistent, no matter who is insuring them, but that we also are being reimbursed for the time and effort that it takes to do that work. And then the other piece to see is it ties in really well with the Food as Medicine bill, and that is to explore pilots and innovative programs where Medicaid funding and other state funding could be leveraged to help address health-related social needs and ultimately to reduce healthcare costs as well. And then this final piece about opportunities for collaboration with key partners, I think is important. There has already been some really extensive work in a learning collaborative that has gone on between the Medicaid MCOs and the state, and really fostered by the Episcopal Health Foundation, who is a key player in many of these conversations as well. That work will continue. There will be need as this action plan is implemented to consider who else needs to be at the table besides the MCOs. And as a pediatrician, I would advocate that providers really need a space or need a place at that table too, because we're the ones who on the front line are seeing and caring for children and families who are affected by food insecurity, and who are many times working in our office with the relationships that we've already established to help connect patients to the resources that they need. That also includes a commitment from the state to engage stakeholders in this process as well, and to have an internal work group that will continue to be focused on how the state can most effectively drive those things. So I am really excited about the fact that for the first time, we kind of have a blueprint for how the state wants to move forward. They've also released a timeline. I didn't put it on the slides because honestly, once you start to shrink it down, it gets tiny and nobody can really read it. But the first slide, the slide that was immediately previous to this, that link will be active when you receive the slides, so you can go to the whole action plan from HHS to look at that if you want to. It includes that timeline, and what you will note is that the vast majority of the early goals, the ones really looking starting this year, moving into 2022 to 2024, really many of them are focused on food insecurity, with the hope to then broaden those things to housing and transportation over the next few years. Next slide. I did want to provide a little bit of context before we move to questions and answers, because I think what's happening in Texas is really exciting. We have some momentum. There's both legislatively and administratively to help make these connections between hunger, food insecurity, and health. But I also want to just note that that all of these policies take place within the context of a whole host of federal policies that impact these pieces. As you all likely know, for example, WIC and SNAP are actually both federal programs that are administered by the state, and so the state has much control over how it's administered, but there are also requirements built in at the federal level. Jaimie mentioned some of those as she was discussing the college student hunger bill and SNAP access bill that we currently have. And so I just wanted to give a couple of slides to think about where that context is at the federal level for those of you all who may be interested in engaging in advocacy on those levels. And so one piece is that this fall, actually September 28th, this past fall, the White House held for the second time a conference on hunger, nutrition, and health. The first one had actually been held in the Nixon administration. So it had been a moment since one of the White House administrations had really decided that this was an area they wanted to focus. And their real goal is to reduce hunger and food insecurity and improve health outcomes here in the next decade with meaningful policy changes. One of the things that they have done that I think is really remarkable is they have leveraged private and public sector partnerships. They have commitments for more than $8 billion of investments from nonprofit organizations, commercial food organizations, food distributors, to work in these 5 areas that they've highlighted. Improving access and affordability, integrating nutrition and health, empowering consumers to make and have access to healthy choices, supporting physical activity, and enhancing nutrition and food security research. I will highlight, for example, that the American Academy of Pediatrics, an organization that I'm involved with, and that is the national partner to our state, Texas Pediatric Society, has committed to provide training to all 67,000 pediatric members of the AAP over the next 3 years related to food insecurity screening and referral in clinical settings. There are some wonderful toolkits already available that have been highlighted, but there will be more educational opportunities coming both in in maintenance of certification opportunities like Part 4 QI projects, as well as integrating these trainings into conferences that are already being provided. And those will be provided as member benefits, right, at no extra cost to those members. And then if you want to, next slide. So I called my, my trustee, American Academy of Pediatrics Federal Affairs staff member who deals with child nutrition programs this week, and I said, is there anything happening besides the Farm Bill in the 118th Congress related to childhood nutrition programs? And she was like, nope, the Farm Bill is where the focus is for this year, and it really is what we need to do to at a federal level to be able to ensure that children continue to have access to SNAP. Some people hear Farm Bill and they think, wait, this is an agriculture bill. It has to do with USDA subsidies. And it does. The Farm Bill is a huge omnibus piece of legislation that it covers a large number of pieces. One of the most important pieces that it covers, if you are passionate about food insecurity, is SNAP. And so advocates from across sectors, from pediatricians to the Food Research Action Center to Feeding America, will be working to help ensure that eligibility remains the same, so we don't cut people out of the SNAP program, and that benefits remain the same in this Farm Bill as it moves forward, so we don't lower benefits for families that are in need. And so there will be plenty of opportunities as that moves through the process to really look at how we can engage individuals, people who are members of the Food Policy Roundtable, the Texas Pediatric Society, and other organizations to reach out to their legislators to advocate for strong SNAP benefits in the Farm Bill. Now I think we are gonna turn it over to questions for the last little bit.
Yes, so Jaimie will be joining us as well. So that we have several questions here. So lots of really good insight that was presented, and now we can kind of follow up. So Jaimie, I'm going to give you the first question. So one of the things I looked up is what's the average cost of a new car with Kelley Blue Book? And in February, it was like, it's over $49,000. And in 2021, it was $37,876. So it's gone up a lot just in the last few years. So the question is, for the vehicle test, if you exceed any of those limits, you fall out of eligibility. Do you fall out? And also, was it the cash one that hasn't been updated since 1974?
Yeah, so good questions. And to clarify, so there's 3 limits technically that we're talking about when you think about SNAP and assets. The 2 of them are related to vehicles. $15,000 for a family's first vehicle that they own, and then $4,650 for any subsequent vehicles. So that's like if you're a 2-parent household, you own 2 cars, the limit for that second vehicle is $4,650, and that is what hasn't been updated since 1974. It comes from the federal limit at that time. There is a liquid or cash asset limit as well of $5,000 for a family. And if one of those vehicles or both exceed the limits that are set, they apply the excess value of your car applies to the cash limit. So for example, if you are a family and you only own 1 car and that car is worth $20,000, that's that $15,000 limit plus the $5,000 cash, then you can still qualify as long as you don't have any additional cash assets that apply to that limit. Because if you have additional, money in your savings account, that's going to put you over. I hope that kind of clarifies that. And to be clear, having a vehicle asset limit in the first place is a state option. So most states don't even evaluate the value of somebody's vehicles when they apply for SNAP. We tried for years unsuccessfully to get the Texas legislature to just eliminate the vehicle asset test in its entirety. And that was not a popular option with the legislature. And so we feel like this bill that modernizes the limits by applying an inflationary adjustment to the current limits, that is a acceptable compromise that we feel is has a reasonably good chance of passing during this legislature. And then it will adjust the limits every year going forward for inflation as well. So it is a permanent solution to this problem, because having those fixed numbers in statute, means that we're going to have to come and re-advocate for them to be updated over and over and over. And I don't want to be back at the legislature in 10, 15, 20 years advocating for them to change this policy again. So we're very supportive of the inflationary adjustment.
Great, thank you. So Dr. Smith, a few questions for you. So the first one is non-medical drivers of health just new language for social determinants of health, or is there a distinction?
I think it is new language. It's more precise language, I think, is the attempt, but it's really describing those same things. If you think about the way I've always described social determinants of health, it's the conditions in which a person lives, plays, works, and learns that can impact their health. And so really that definition is very similar. I think that the attempt is to recognize that there's a broad spectrum of those things, but they're not tied necessarily to healthcare access, right? Like it's all the things besides the healthcare access. So food, transportation, employment, education, all of those things would fit within that non-medical housing, obviously within non-medical drivers of health.
Good. So I have a follow-up for you. So in the plan, it mentions data networks. Is there a plan to send and receive bi-directional referrals between healthcare providers and community-based organizations through direct messaging, a platform, ask help, etc.?
That's a really good question, an important one, because we know that closing those loops on referrals can be really, really valuable. So this plan is giving an infrastructure. So that may be a piece that comes out of the plan, right? Part of the plan is like develop and implement these systems. So part of the developing will be, is there a need for those systems statewide? There are some of those systems that already exist. You mentioned Find Help as one of those. And in some communities, those do involve bidirectional information. As healthcare providers know, bidirectional information can be a real challenge because we need to deal with protected health information and protected personal information and HIPAA, and many of our social needs partners, our health-related social needs partners, also have their own need for confidentiality. And so I think that is one of the pieces that I really would encourage the external work group to continue to push and to think about as this plan is developed and fleshed out around those pieces.
Yeah, I really like this model because it shows there's a continuum of care and extends it from healthcare to public health. So really the way we should move. So Jaimie, a question for you. Does the definition of medically tailored meals include raw, fresh produce?
Yeah, so technically, no. Medically tailored meals is a prepared meal. So obviously, it would include produce, but in the context of the meal itself, and they're usually served, hot meals to folks who have restrictions or other limitations on preparing food for themselves. I will mention that we are working with Chairman Olson to potentially amend the bill to also include something called food RX or food prescription, which is still a medical intervention, you know, a diet prescribed by a healthcare professional. But in that situation, the food is delivered in a healthy food box, and the participant or patient prepares it for themselves. So it's kind of a step down from medically tailored meals, which are for people who struggle to prepare their own food.
Well, you anticipated one of the other questions I had, so that was very good. So, Dr. Smith, I have another question for you. Is there any reason why the data infrastructure could not also support Medicare and other non-Medicaid patients? They experience food insecurity too.
Absolutely. So that is one thing that I think sometimes as I'm working with clinics about implementing screening and referrals within their clinic, sometimes I get the answer of like, well, we don't see very many patients on Medicaid, so we don't need this program in our clinic. And we know that food insecurity is high among senior citizens, so who are primarily on Medicare. And then that there are certainly families who are not on Medicaid who still experience food insecurity. As we talked about at the very beginning of this series, food insecurity is often episodic, and a family may have something happen to them in a short period of time. They lose a job, they have a health problem, where they miss work, and then they also have the healthcare bills on top of that. And so families who are not chronically food insecure still may experience food insecurity episodically throughout the year at times. And so that is a really important piece to acknowledge, that this is not something that only applies to families who are on Medicaid or CHIP, or who have children on Medicaid or CHIP. Our systems are not great at talking to each other. Generally. And so a lot of the data that HHS will be able to collect is related to coding and billing of healthcare encounters. So they can only do that for the patients that they, like for the families and clients that they serve. There is work being done at the federal level, especially within Medicare and CMS, to look at utilization of codes and bills for non-medical drivers of health as well, so that we may be able at some point in time to pull those things together. I think the challenge around privately insured patients is bigger. The one thing I will say is that many of our MCOs that provide coverage for provide Medicaid programs in Texas also provide private insurance programs. And so that may be a place for us to leverage those commonalities, is looking at organizations like United, who insure a lot of people through employer-based insurance, but also provide Medicaid-based insurance for many people. Can we collect information across their systems?
Excellent. So another question, and either one of you can jump in for this one, is I've had many families go through the mountain of paperwork to be eligible for SNAP benefits and get $10. Any initiative to have a minimum benefit if a family or individual is eligible?
Yeah, I can take this one. So the minimum benefit is a little bit more than $10 these days. It's, I think, $23 per month, which is not that much better than 10, I admit, but just to be clear. And yes, so, there are, I think, states that are doing very innovative things around SNAP. Like instituting their own minimum benefits by using state funds to raise. So, raising the minimum benefit to 50. There are also efforts in some states to provide benefits to immigrants and other folks that are technically not eligible for SNAP, but they use their own state appropriated funds to extend eligibility to those folks. And there is a conversation on benefits adequacy, happening at the federal level with the Farm Bill right now. Unfortunately, SNAP is also the target of a lot of conservative legislators right now who are looking to cut the federal budget as part of the debt ceiling negotiation. And they have their eyes set on SNAP as a program to cut. So we're mostly focused on protecting the benefits that folks do have right now, but benefit adequacy and minimum benefits are always kind of at the top of the list in terms of our advocacy.
Thank you. We're right at 1 o'clock, so I want to thank our speakers again, Dr. Smith and Jaimie Olson. So really great to have y'all here and to have your insights on this important area. I also want to thank the Michael and Susan Dell Foundation that funds the center and these webinars. And then I just wanted to let y'all know that we will be sending out a link to the slides and to the recording of this webinar. So feel free to pass them on to others who might be interested. I'm sorry we weren't able to get to all of the questions. We had a lot of questions coming in, so definitely a lot of interest in this topic. So thanks again. Y'all have a great rest of today, and we'll see you at the next webinar. Bye, everyone.